So we have 25 people on board and a few still in the process of joining. So a
Yeah.
really nice group today. Lots of names everyone recognizes. So thank you so much for coming, David. It's, as always, an immense pleasure to have you here. Oh, wait, you're muted.
Thank you very much. It's a great honor to be talking to everyone today. Appreciate the opportunity.
And for those of you that don't know David, but I'm assuming that's either none or very few of you, Dr. David Weber is an MD, PhD, MPH, sorry, and a distinguished professor of medicine, the Associate Chief Medical Officer for UNC Medical Center, the director for the Department of Infection Prevention at UNC Medical Center, and as of this year, the president-elect of SHEA, the Society for Healthcare Epidemiology in America. Have I missed anything, David?
You got most of it, so that's fine. Thank you.
It's a pleasure to have you with us, David. And we'll start. Most of us will turn down our camera to make sure we don't lose the quality. Can you share the slides? Everything works?
Yeah, what I'll do is I'm going to work through two papers that I wanted to present that I think were excellent follow-up to what Dr. Cannon presented last time. There won't be any slides for this, but I'll work through the papers and we can discuss them. Can you see my screen now?
Yeah, perfectly.
Or not? Good. Okay. Let me make it a little bigger, make it a little easier for both of us. Good. Okay. So I wanted to talk about two very important papers that I think were an excellent follow-up to what Martin talked about last time. Probably the best evidence of transmission of healthcare-associated pathogens, the role of the environment, is an excellent paper that Dr. Cannon presented, the update, is the risk that patients, when they go into a room previously occupied by a patient who had a multi-drug resistant pathogen, MRSA, VRE, but certainly others like CRE, is at higher risk for acquiring that pathogen than if they go into a room without such a patient. But what I wanted to focus in on are two papers that look at the transfer of pathogens to and from patients, healthcare providers, and medical devices during care activity. And this is a systematic review and meta-analysis, and adds to what the previous paper showed. So here we're now talking about the mechanisms of transmission as opposed to just the absolute or relative risk. And so this is a paper by Dr. Wolfsenberger from 2018, so several years ago. And the objective, as you can see here, was to the transfer of pathogens may spread antimicrobial resistance and lead to healthcare-acquired infections. And they performed a systematic literature review to generate estimates of pathogen transfer in relation to a healthcare provider activity. And for this review, they did a whole series of looking at a whole series of different databases there. I'm not going to go through those. They included studies that, one, quantified transfer of pathogens from defined origin to a defined destination surface, reported a microbiologic sampling technique, described the associated activity leading to transfer. For patients that reported transfer frequencies, they also extracted the data and estimated the proportion. It's impressive. You can see here, they identified 13,000 articles. I don't hope to try and do a literature review that I have to look at 13,000 articles. They included 32. Most examined transfer from patients and their environment to healthcare provider hands, gloves, and gowns, with an estimated transfer frequency of 33%, 30%, and 10%. As you can see, the greatest risk of transient colonization is of hands. And obviously, that's why hand hygiene, of course, remains our leading protection mechanism in the transfers Dr. Didier Patel has talked about for a very, very long time. Other articles address transfer involving the hospital environment and medical devices. And the risk factor analysis in 12 studies suggested higher transfer frequencies after contact with moist body surfaces, mucous membranes as opposed to skin, longer duration of care, and care of patients with invasive devices. All of those make perfect physiologic sense, but it's nice to have data. So with that, I'm going to go through this paper, and then I'll go through another paper that adds on to this information. They say right here, hands are the most important vectors, and we'd all agree with that. But equipment such as stethoscopes and other shared equipment may also serve as a vector for pathogen transfer. And I should say in the last few years, shared medical equipment has become increasingly realized as an important transfer there, and something we need to pay attention to. They note here, which I really enjoyed that number, each patient is visited by a median of 3.5 healthcare personnel per hour. And this is true when we've done outbreak investigations, even for patients in the hospital, at least at an academic center, for just a few days. We often find more than 100 different healthcare providers have had contact with that patient, mostly nurses for a median of 3 minutes per visit. And the patient environment and tax skin and body fluids are touched in 33, 27, and 18% of visits respectively. And although not mentioned here, the environment around the patient, bed handrails, over bed table, light switches, and others is frequently touched as well. They note here that prevention policies such as standard and isolation precautions, particularly hand hygiene and use of gloves and gowns, aim to prevent pathogen transmission there. So the studies that they looked at are listed here. First, a study in a defined healthcare setting. They did inpatient or outpatient. They also included nursing homes here. The study reported transfer of bacteria, viruses, or fungi. Most of the studies have looked specifically at the bacteria. The healthcare provider activity associated with the transfer was described. They did some type of molecular analysis, either genomic or pulse field gel, in that evaluation. The origin and destination surfaces of the patient's body and the immediate environment were assessed. And then they also had to report on the microbiologic sampling method. Contact plates and swabs would be used for surfaces. The glove juice method is used for looking at, it's probably the best method for looking at hand contamination, although there's certainly others. They did a standardized template and abstracted a whole variety of information here, the microbe, the setting, the surface, number of transfers, interactions, microbiologic sampling, all of that was done. Here, they did subgroup analyses here for a variety of issues, pathogenic bacteria, examining destination surfaces, surface of origin, healthcare provider behavior. Well, let's go down and look at the results, although the best data is in the table, but we'll look at that in a minute. There, after they excluded 12, almost 13,000 articles there, they did a full review of 189 articles, 32 articles met eligibility criteria. That's in the table you can look at. I'm not going to go through the list specifically there. So a total of all studies were conducted, and this is something that would were in high income countries. It certainly would be useful to have similar data in moderate and low income countries there. So that's one thing that would, additional research that would be useful. Sample size ranged from 3 to several hundred. The surface of origin or the environment was noted in 74% of studies there. Common destination service were hands, gloves, and gowns, and they focused more on transmission to the surface to those than from the hand, gloves, and gowns to the patient. We'll talk more about that in the second paper. So we have hands, 56%, gloves, 47%, and gowns and uniforms, 22%. And then they did mention, of course, shared equipment is mentioned in several of these papers, probes, stethoscopes, and others. And I think there's an increasing awareness of this. I think probably Kurt Domsky is one of the leading researchers on looking at the transmission via shared medical objects there. And they talk about all the different clinical activities that were studied. Some just were actually experimental, brief touches or handshakes. Others were more complex, actual medical and nursing interactions. So here's their study, starting out with 16,000 articles identified through the database. Duplicates removed, they ended up with 13,000, excluded roughly 12,900. 189 they actually assessed, and they ended up with 32 papers there. Full text was excluded for 157 there. Various microbiologic techniques we used there in different studies, including swabbing, contact plates, glove juice methods. And at some time, I'm happy to come back and talk to you because we've studied both the best ways of sampling hands and the best ways of sampling surfaces, and I can discuss some of our papers with regard to that there. Most studies estimated the frequency during standardized tests in real-life situations, 76% there. And hand and glove contamination rate from 0% with VRE after standardized mock radiologic procedure to 100%. So it all depends on how long you touch and what you touch. After to 100% of human papillomavirus after treatment of urethral warts. There, most of those contaminations were obviously in between there, and you can see here, glove gown contamination 2 to 37% for VRE, MRSA and Acinetobacter 100% for staph. Ultrasound probes contaminate to 100% with skin bacteria there. The pooled frequencies you can see here, as we already talked about, of bacteria to hands and gloves, 33%, and 30% with lots of heterogeneity measured there. For the current proportion of transfer to gowns into hands after glove removal was 10%. And 3%, again, emphasizing, which is often, sometimes forgotten by our healthcare providers, sometimes often, that while gloves protect you from acquiring something, the hands often become contaminated when you remove the gloves, and hand hygiene must always be performed after glove removal, something that we're always trying to emphasize to our healthcare providers there. We'll come back. These are the key figures. We'll look at that. The burden of transfer was generally low, 10 to 1,000 organisms there, but one did report much higher. This is probably consistent with the fact that most studies of surface contamination show 10 to 100,000 organisms per square centimeter. So surfaces are relatively less contaminated than something like a colonoscope would be there. And they did a risk factor analysis. 7 authors described contact with moist body sites, mucous membranes, invasive devices, and duration was also important. Again, none of those are surprising. So let's go down quickly on the discussion here. Despite this, here are some of their conclusions. Transfer of pathogens between patients and their environment and healthcare providers and medical devices occurs frequently during patient care, with transfer to hands and gloves occurring more often than transfer to gowns. Higher frequencies of transfer associated with moist body sites, invasive devices, and longer duration of care, and higher CFU counts are found in contacts with moist surfaces. And I'll go right down here. And one of the reasons I picked out this paper, of course, is that they appropriately note that DDA has been the leading proponent and the leading researcher in the importance of hand hygiene. And of course, they note right here, hands are commonly cited as the major vector for transfer of pathogens in hospital. Gloved hands are also active vectors. If gloves are not changed, according to the guidelines, our hands are not disinfected after the gloves. And they note that Dr. Pate provided an evidence-based model for hand transmission during patient care, identified 5 steps in the transmission, patient-to-patient transmission by a healthcare provider hands. I'm not going to go through that. They go through all the different studies, but I'm not going to go through that here. So here is the key paper or key figure, and they just broke it down because at this point in time they really had the most information on VRE and MRSA. These days, I'm sure we could construct a model like this for things like C. difficile, certainly, and probably norovirus, and maybe others such as ESBL organisms or CRE. So here is the patient or the environment, and they didn't really distinguish between that, but they note via hands the contamination rate for VRE, 11% during direct patient care in an ICU, and they have all the references. I think this is an excellent way of really demonstrating this. So here we have patient environment via hands to another patient. 31% of stethoscopes become contaminated, although demonstrating the transmission of pathogens via stethoscopes. Easy to show that they're contaminated, harder to show that their importance in transmission. Here from the patient or the environment, and here's the environment there, also going to hands. Patient's more important probably than environment, both are important. Depends how you measure it. If you're doing an outpatient mock procedure, it's relatively low. But when we actually look at the direct patient care, here 75% by Mary Hayden and 27% in ICU. Here is another study by Mary Hayden, another phase of the study there. Then you look at gloves, again, standardized physical exam, 63%, touching bed rails or table for 5 seconds each. Notice that, 46%. So this is transmission from environment to the gloves, and again, higher by Mary's study of 66% on direct patient care. In general, when you do controlled studies, you pick up more bugs by bare hands than you do by gloves because of the oils and things in the hands. So you get a little better transmission from the environment to the hands. Again, here, hands after removal by gloves, quite important. Again, showing why hand hygiene always must follow removal of gloves. 0 to 7% in this study by Mary and Dan Morgan, 14% in this other study here. So certainly something we need to emphasize there. Gowns, the lower rates of acquisition or contamination of gowns through care. They didn't really break it down by their actual activities. Usually the gowns get contaminated when you have very close contact with patients, or you're leaning over the patient's bed and the gowns are directly contacting things like the bed, the mattress, or the handrails there. And the exact role gowns play in patient-to-patient transmission is not quite as clear as hands or gloved hands. Well, let's go down and look at MRSA now. A little less data, but still substantial data. Patient or environment to hands. Patient here, 38% picked on via hands on there. Patient-to-patient transmission by MRSA here. Again, here's patient environment here. And you can see here 45% by imprinting gloved hand on patient environment there. And similar numbers by touching the patient there. Really depends where in the environment you touch. Things like a ventilator are heavily contaminated, by the way. People talk by which would be a separate discussion. People talk about high touch surfaces, and you can define them, and we have. But the data does not really suggest there's lower contamination of a high touch surface like a bed rail, which is touched multiple times a day. than a light switch, which is touched only a couple of times a day, turning it off and on. So in our guidelines here at our hospital, we emphasize that all touchable surfaces in a patient's room should be disinfected, ideally daily, and certainly carefully a terminal disinfection. But guidelines which recommend focusing only on high-touch surfaces, really, I don't think there's evidence for that. We can determine what's a high-touch surface, but our studies have suggested that there's the same levels of contamination for high and low-touch surfaces. That is different than non-touch surfaces like the ceiling or the high walls, which have very uncommonly have contamination. And here's again, hands after removal, after gloves, 3% here by Dan Morgan. And then gowns, lower rates here, but certainly important there. Well, we can go down now and look at their comments here. Where the healthcare provider attire plays a role in the transfer of pathogens is a topic of considerable debate and controversy, and I would agree that it plays a much smaller role than hands or gloves there. They go through some of their limitations here, which we should do. First, the studies were very heterogeneous there, particularly the number of organisms. They found a great variation there. Let's see, second here. In 10 studies, the origin of the surface was not sampled. In others, only the colonization status of the patient with MDRO pathogens was indicated, but not the exact colonizing body site or contamination site of the inanimate surface there. Third, during the multi-step prolonged interaction, the exact origin of the transferred microorganisms remains unknown, and that's why I'm going to focus on the next study, which was a more carefully done study looking, or a carefully done study looking at the transfer of mechanisms there. And these three issues preclude making a generalized statement about the exact transfer frequencies here, but I'm going to provide some data on that a little later. And in summary, this systematic review unveiled a knowledge base coming from heterogeneous studies, and is quite an important study in my mind that provides very important data demonstrating the importance of surface disinfection, also hand hygiene, and particularly hand hygiene after glove removal. With that, I'm going to stop before I go on to the next study and ask if there are any questions or comments anyone wants to make.
You can just raise your hands on the chat, or otherwise, yeah, Jean-Yves, if you could just present yourself quickly before asking your question.
Yeah, sure. So I'm Jean-Yves Maya from Cardiff University. David, thanks for that. Just a rapid questions. You know, you mentioned a few times moist surfaces, but what's the definition of moist surfaces in those papers? Because obviously the level of moisture would be very important. And I think you mentioned a link about transferability on obviously moist surfaces, but do they provide a definition of what is moist?
Yeah, they what they talked about, and again, it's heterogeneous in the different papers, but they're talking about mucous membranes, particularly mouth, anus, and vagina, but also some included things like open wounds, as an example, non-intact skin with open wounds, such as a burn patient would have, as an example there. I don't think that the papers, there are enough papers out there to really be able to break down what the risk is of a gloved hand and, you know, each of those different moist surfaces there. But clearly, a moist surface compared to dry, intact skin leads to more transmission to gloves or hands. Well, presumably you'd all be wearing gloves for that, for those activities, but more transmission to the gloves in those cases than just touching dry skin.
Okay, thanks. If I may, so they haven't referred at all about moist surfaces in relation to environmental surfaces. It was all to do with the patient.
I have not seen that really, where people have done studies of like a water contaminated surface versus a bed rail or a bed rail with blood on it. There, I would think that if there's a liquid there and it's contaminated, again, it will spread more easily onto a glove or a hand than it would not. But I have not seen careful data on that. There is data, obviously, on which environmental surfaces are more contaminated, and in general, it's those that are closest to the patient, not surprisingly, like bed rails and overbed tables. Others that have lots of contact and maybe secretions, like ventilators, are also more heavily likely contaminated than you would find on other things like a telephone. And of course, there's heavy contamination in the bathroom, not surprisingly, on the floors, toilet seats, toilet handles, and so on, has heavier limits of contamination. That said, most of the surfaces have, somewhere between 10 and 100 organisms. They're not as contaminated as you would find on a medical device that had direct contact with body excretions and secretions, like a bronchoscope or a gastrointestinal scope.
Thank you. We have a question from Jared.
Yeah, hi, Jared Daniel, physician up in Portland, Maine. Thank you for the summary. You mentioned that at your institution, it's standard procedure to cleanse all surfaces in patient rooms. Do you have a way of standardizing that, and also a way of monitoring or observing or ensuring that it is completed properly?
Yeah, yes. And first, let me talk about standardizing that. We do have guidelines on what needs to be cleaned. The biggest issue for that, for the touchable surfaces, is making sure that each group knows what they clean. So the nurses like to clean the medical devices that you really don't want people touching buttons, things like EKG machines, IVAC machines, ventilators, monitoring equipment, and obviously EVS is cleaning things like environmental services like bed rails and surface tops. And that varies from unit to unit. So we have every single unit has their own, we get the EVS and the nurses together, and sometimes others like nutrition, and each unit has its own algorithm for what gets cleaned, because they're different in an operating room versus an emergency department room versus a neonatal ICU room. And we have found over the years that sometimes things don't get cleaned and disinfected because everybody assumes the other person's doing it. So each unit has its own list. We also monitor our cleaning, not disinfection, but cleaning, using fluorescent dots as described by Phil Carling. About 5 or 10% of the rooms we put the dots in, and we try and put 3 to 5 dots in. We have found a Hawthorne effect. That is, if all you do is put the dots on the telephone and the bed rail, it doesn't take the environmental service workers very long to figure out that's what they have to spend a special time. So we have a list of about 20 or 25 surfaces. It's not feasible to put that many dots down. So we pick 3 to 5 randomly. And what it means, the supervisor will go and put the dots down, the worker will go in, and then supervisor will follow up. If they're not clean, there's immediate feedback to that worker. Trying to tell him a month later that he missed some spots is not very effective. We do that in about 5 or 10% of the rooms. They're picked randomly, and making sure we get all the different shifts for the EVS workers. That is summarized, and I can send that around to people in a grid every month by our EVS director, who reports to our hospital infection prevention committee. And they get the green dots, yellow dots, or red dots. The goal is having at least 90% of the surfaces cleaned. And we monitor that, and that's reported to the committee every month, with, obviously, if we see a unit is falling behind, we would intervene. And I should say we also monitor hand hygiene using an app on the phone. You don't rate yourself, you rate other people, and we have something like 1.5 million observations now. And again, we ask people to give immediate feedback if they see somebody not performing hand hygiene correctly. We have, interestingly enough, grouped that feedback, which occurs in about 30 to 45% of the time. We'd like it more frequently, but we're happy to get it almost half the time. And it tends to flow more downhill than uphill, meaning if you group the healthcare providers into professionals, nurses and doctors, and then paraprofessionals, occupational therapy, physical therapy, dietary, and then the non-professionals like EVS, it's about twice as frequent as each of those levels that it flows downhill. So twice as likely a physician's are going to mention to an occupational therapist, and then twice as likely they would to an EVS worker that they didn't perform it correctly than going uphill. But we encourage people through the feedback not only to say when someone has made an error, but also when they notice that they did hand hygiene, to congratulate them on hand hygiene. And we do monitor that and discuss it monthly. And we do have set criteria for what we'd like to see, which is over 90% compliance with proper hand hygiene, which we do reach.
Okay, that's fantastic. And do you have, obviously you have an educational program as far as hand hygiene is concerned, and how often is that performed at your institution?
Well, we do a couple of things with hand hygiene that I think are a bit, one is everyone has to take and pass a yearly test on infection prevention. Hand hygiene's included in that. The other thing that we do, which may be a little more unique, is each year the hospital sets a series of goals, somewhere between 3 and 10 goals that we need to reach. And if we reach those goals, we reached all the goals, then all the supervisors in the hospital get a 10% bonus, and everyone in the hospital who's not a supervisor gets a 3% bonus. And this doesn't depend on how good you are personally. The goal would be for hand hygiene, let's say it is maintain over 95%. That's our goal. And if you reach that goal, then everybody gets a bonus. And if you don't, they don't. And so that's, hand hygiene might account for 3% of the 10% bonus. And so it really is a group activity that everybody has to monitor everyone else, because if you don't reach that limit, then nobody gets that piece of the bonus there. So they put real money behind that. We always have at least one infection prevention goal for those bonuses in there. Obviously, individual employees get individual bonuses for good performance, but here it's a combined group, and hand hygiene is frequently one of those issues. Other things might be things like fall prevention, or as an example, or appropriate medication use there. But those are some of the things we do to enhance hand hygiene, plus talk about it quite frequently. So we have what we call a tiered system in the hospital for solving problems. At 9 o'clock each day, every group in the hospital, including infection prevention, meets and discuss what's happening and what we can do, what are the problems and what we can do to solve them. Then they would move, let's say your medical ICU would do it at 9. At 9:30, all of medicine will meet. Something gets escalated up to the next level. And then at 10 o'clock, one of the 6 senior leaders in the hospital, like the president, run a problem. And any problem gets escalated up to that group with the idea, let's solve every problem immediately. Infection prevention has a weekly time, 5 to 10 minutes, to update senior leadership every week about various issues related to infection prevention. Given the 5 or 10 minutes, we don't cover everything, but we rotatingly focus on things like hand hygiene, surface disinfection, reducing central line associated infections. So those are some of the education efforts we do.
Thank you. Thank you, David. Sorry, I need to interrupt the question and answer so that David could actually introduce his second paper, which is his original work, and we'll come back with all questions and answers after your presentation. Thank you, David. Fantastic.
Thank you very much. So this is the next paper I want to present here. This is a more recent paper, and it's a prospective study of transmission of multi-drug resistant organisms between the environment. It's led by Luke Chen, a colleague of ours at Duke. You can see myself and Dr. Rutella are a part of this study. Duke and UNC fight vigorously on the basketball court, but We do combine, and we actually have combined CDC-supported epicenter, which funded this particular study there. And this was part of a different study called the BETTER study. I'll just briefly describe the BETTER study. It was a 4-arm cluster randomized control trial looking at whether UV light for terminal disinfection reduced the risks of transmission when patients entered rooms. And there was a control arm. There was a quaternarium ammonium arm. A quat arm was the control, and UV was the experimental. But they did it slightly different. For C. difficile, we also used a chlorine product there. And there was multiple hospitals, and each hospital went through each of these events. But this study was nestled within that larger study there. So you can see here from this. So this was a prospective study. Environmental surfaces frequently contaminated. This prospective study was performed to characterize the nature of multi-drug resistant organisms between the environment and patients using standard microbiologic techniques, molecular techniques. So there was molecular typing of all of these. It's done at 2 academic centers, which are Duke University and University of North Carolina there. It characterized the nature of bacterial transfer events between patients' environments that were previously housed with one of 4 marker organisms, MRSA, VRE. Here we've also added C. difficile, a multi-drug resistant Acinetobacter. Environmental and patient microbiologic samples were obtained on admission to freshly disinfected patient rooms. So after the room, terminal disinfection, then they went in and sampled it. Repeat samples from the room surface and patients who now entered the room were taken on days 0, 3, and 7. Each week, the patient stayed in the room. The bacterial identity, antibiotic susceptibility, and molecular sequences were compared. We enrolled 80 patient room admissions. 9 of these patients were asymptomatically colonized at hospital entry, showing roughly a little more than 10%, showing the importance of asymptomatically colonized patients in potential transmission. Hospital contaminated with MDROs despite terminal disinfection, 55%. Relatively small numbers in terms of quantitative, but again, even at 2 very good hospitals, EVS, our ability to completely disinfect surfaces, difficult. And then microbiologic transfer events, which are abbreviated MBT, either to the patient, the environment, or both, occurred in 12 patient encounters at 18.5% there. So that is the final conclusion there, and we'll go through the paper. It's a shorter paper than the one we just went through there. Let's see, I do want to mention this paper. Although our study only focused on strategies that improve terminal room disinfection, the results suggest that the environment is responsible for at least 10 to 30% of MDRO acquisitions. So quite an impressive number. Certainly, I think transmission by hands or gloves is quite important. But this is the first time you can begin to gain some assessment of what the percentage of that is. So again, this is perspective we performed at 2 large academic hospitals, Duke University and my hospital there, Duke Regional, as well as at UNC. Let's go down here, subject enrollment. They prospectively identified subjects for enrollment. All patients were admitted to a participating hospital there. And study personnel sought patients housed in rooms where the antecedent patient was placed on contact precautions for any reason, and they had to have an estimated length of stay for more than 48 hours. And informed consent was obtained since they were getting patient samples. Study personnel visited it on day 0, 3, and then and 7 there, and they got samples both from the subject, the patient, as well as from the environment there. And here, in terms of, they did a large number of body sites there, which included nares or oropharynx, axilla, and perineum at each study visit, and if possible, a fecal sample there. And then they looked at 7 high-touch surfaces there. That included bed rail, overbed table, bedside table, armrest of chair, sink, toilet seat, and floor of the shower block. I think our data, as well as Duke's, would all suggest those are the most contaminated surfaces. And we use Rodak plates, so you could get qualitative and quantitative numbers at the same time there. Outcomes were really the baseline and subsequent pattern of patient colonization, hospital surface contamination, number of microbiologically, molecularly proven bacterial transfer events. There, we also looked at 2 secondary outcomes of interest: direction and timing of bacterial transfer events and clonal relatedness there. Let's see, standard statistics we used. We talked about here 80 patient room encounters, 68 wardrooms. Most of the patients were white, slightly more were female there. Patients were on general medicine and hematology oncology. So again, a limitation is this might have been somewhat different in a surgical or pediatric group of patients there. Of the 80 patients, 18% were discharged before the 3-day visit, showing how quickly we turn over patients in the hospital. So, but 81% did have were able to look at things over time. In total, 9 patients were asymptomatically colonized there, 11% at the time of study entry. MRSA in 6 encounters, VRE in 2 encounters, C. difficile in 2 encounters. Notably, 1 patient had both MRSA and C. difficile there. Hospital rooms contaminated, we mentioned 55% at the time of enrollment, and here is what they were contaminated with. That we looked: C. difficile in 26%, VRE 22%, MRSA in 15 and 18%, and Acinetobacter in 11%. And importantly, also contamination with multiple MDROs was observed in 23% of the rooms there. But I will point out that the bioburden, when we looked here, is relatively low. And I've talked about that earlier here with this study, median of only 6 and a range of only 2 to 16, which is one of the reasons when we look at the effectiveness of surface disinfectants, if you can kill 10 to the 3 organisms, you're probably going to have a substantial reduction in the likelihood the environment's going to transfer organisms. Detected 12 microbiologic transfer events among 65 patients. Most were associated with staph, some were associated with VRE, and 5 were associated with C. difficile. None were associated with Acinetobacter. And then they broke these down, and I'll show this in a table in a minute here. These events, to 3 categories there. 4 events occurred from patient to environment. 4 occurred from environment to patient, so equal transmission from the patient to the environment the other way. And 2 environment transfer events, a molecularly similar organism was detected. So some of these transfer events were not molecularly proved there, but again, it's likely that many people had different strains there, and we may have missed that by just selecting certain ones from molecular proof there. Let's go down here. I'm going to go to the table in the interest of time, and then we'll come back to some of this data there, but I want to show you some of the tables here. So here's the study, 80 total patients, 65 in the evaluable cohort there. 3 types, 3 isolates failed to amplify. 9 had molecular sequencing. 3 non-clonal bacterial transfer events, and 6 clonal bacterial transfer events. Here's the days between first positive culture to transfer event. Keep in mind, many patients stayed short periods of time, but 80% occur within very short periods of time. So they occur very quickly. Let me make this larger. So here are the demographics again, mostly older patients, slightly more females, mostly white individuals. We had only one collection in 19%, but 2 and 60%, 3 and 21%. Length of stay was the median only 5 days. Rooms with contamination here. Again, you can see MRSA first, VRE second, sorry, C. difficile first, MRSA, then VRE, Acinetobacter here. You can see the relatively low amounts of organisms per square centimeter. And this is really the key table here. So here is the target MDRO. Here is the terminal clean protocol there. And you can notice for C. difficile, some were bleached, but some were clots because they were not known to be colonized there. Here are the different ways they could go patient to environment. Here are 4 events. Environment to patient. Here are the 4 events, 1 with VRE, 3 with C. difficile. For the patient to environment, it was more MRSA. Some we couldn't determine, and by that we meant at the same time, both the patient and the surface were positive. So yes, there was transmission, but you can't tell which way it is, patient to environment or environment to patient. Presence of molecularly related isolates in 2, 4, 6 of those there, and some were discordant. Some were both concordant and discordant there. Now, some of those, did these arise from the environment? Did they get this from the hands of a healthcare provider who transmitted it, or did we not get all the organisms in the environment to the patient? That is, the surface was contaminated with more than one different strain, or the patient was unknown. So I think, in conclusion, these types of studies like this are beginning to add more data to the study we just showed and to the one that Dr. Kiernan showed, really beginning to now to untangle the routes of transmission and the relative importance of transmission between the patient, the environment, and the patient. Study was limited by the modest number of patients and rooms. Microbiologic sampling was not always timed to occur before daily cleaning there. So that may have played a role in some of our numbers. So with that, I'm going to stop and ask for questions or comments on this paper. And thank you.
Thank you.
Fantastic. Thank you very much. Maybe David, if you could unshare your screen so that we can see people speaking, and in case you need the paper to answer questions, that would be nice. Thank you very much. Fantastic to go through those 2 papers, the last one being unpublished yet, as far as we can understand from your file. Thank you very much. Before Bunny had to leave, but he had a question regarding the first presentation and the first paper, whether the type of gowns that were used in the paper were given, or even whether it was analyzed in the meta-analysis, which is in the systematic review, which is not clear to me either, whether disposable gowns or reusable gown. I'm not sure. The answer is in the paper.
Yeah. In general, they didn't comment on that in the paper. So there obviously, one would presume there'd be a lower risk with disposable gowns than with other gowns. I should say, by the way, at some point we can present it. We have done a study of gowns that were impregnated with an antibacterial compound to see if that made any difference, and the answer was no.
Yeah. Okay, I will return to Alexandra. We'll share the discussion.
Yeah. We have one more question from Jean-Yves Maillet, and then I have a few questions myself as well.
Please.
Thanks. Again, David, thank you very much for that presentation. Very interesting paper. I mean, you mentioned earlier on the best method to sample microorganisms from surfaces, and you use the Rodak plate. So is the Rodac the best method you found to sample environmental bacteria? On leading to that is, when you use the Rodac plate, was it on dry environmental surfaces or on surfaces that were just being cleaned, so they're still being disturbed?
So if your interest is getting a defined area easily and getting quantitative, qualitative cultures at the same time, Rodac plates are the best. And obviously you can use selective media in the Rodac plates to make it easier to identify certain organisms. If your goal is to get the best recovery, Rodac plates are not the best. They don't pick up everything. And if you have a non-flat surface like a bed rail, which is circular, it's really, you can try and roll the plate around the bed rail. It doesn't work very well. So it won't work very well for that. The best method then would be something like the stomacher, where you take a swab and then you immerse it and elute from that. That gives you wider areas, first of all, and somewhat better recovery. Mostly the advantage there is, instead of just a Rodac plate, which is about 2.5 square centimeters in total, you can sample 10 to 20 areas with a swab, and you can sample things that are not flat there. Although the recovery is probably a little better, it's probably the larger surface area that's important. So it really depends on why you're doing the study. Of course, it takes a lot much more work, because then you have the bacteria in the liquid media. So then you have to isolate them on different culture plates. And if you want to know quantitations, you have to do serial cultures. So the work goes up geometrically, but it has its advantages. Really depends on the study question.
Well, thanks. I fully agree with you. But you made a comment on your results sections where you said the recovery overall from the surfaces were quite low at 6 CFU. Is that an artifact from using the Rodac plate, do you think? Or would you expect actually a bit more microorganisms recovered from the surfaces?
No, I'll send DDA a paper that we've actually looked at that. Even when you use a more sensitive method, you still find, in general, less than 100 organisms per square centimeter on a dry surface. It's just not near as hospitable to growth as obviously human skin is, or other areas. And although we always focus on human pathogens, of course, the surfaces are covered with environmental pathogens, many of which are not human pathogens. And so the microbes are competing in an environment with lots of other organisms for nutrients and other things which are not as widely present, which obviously is different than colonized skin, where almost all the organisms are at least theoretically potentially pathogenic.
Mm-hmm. Thank you. Thank you very much. We have a question from John Boyce.
So, Dave, that was a great talk. Can you just comment on the importance of using a neutralizing substance, either in the plate or in broths that are used?
Yeah, definitely. So some surface disinfectants like alcohol evaporate fairly rapidly, and you probably, unless you're going to sample right after you use it, you don't really worry about neutralizing. But we know particularly that quaternary ammonium compounds will, unless you rub them off, will be on the surface. Certainly chlorine products may have some potential for time, and other ones do as well. So if you don't use a neutralizing solution for any surface sampling, most important when you're actually doing controlled lab experiments, but still important when you're doing surface sampling in patient rooms, then you will artificially find lower numbers than are really there. One of the reasons that the liquid media may be better than Rodac plates also is they may help promote the growth of sublethally damaged organisms as well.
Thank you.
And I should say the neutralizing agent you use depends on what the compound was used for disinfection. We don't have a single neutralizing agent for every surface disinfectant, or it covers all the surface disinfectants at the same time.
Mm-hmm.
Well, thank you for the two last questions and answers. It's clear that your paper and the previous paper, because most of the paper look at use Rodac plate, which is a lot more convenient and, as you say, much faster in the lab. Also, it's already a lot of work to do it when you do it so extensively the way you just did it, right? And I think that we all have this experience in outbreak investigation where we have to do all sorts of things and all sorts of sampling to try to find and detect. And we know we are detecting more bacteria in these conditions than in these regular conditions that you just described in your institution. What I would say, and my very important conclusion from your work, from the work you just presented, is that to look deeply to transfer is complicated. If you do it well, you could definitively demonstrate it. And certainly the way of using the Rodak plates is one of the most conservative way. At least on hands, it was very clear for us. And there was no methods that could identify sort of all the bacteria that we had inoculated on hands. So it's clear that it's very conservative and it gives us the tip of the iceberg, but clearly we can demonstrate very early transfer, and you could demonstrate that even in your institution with so much careful handling of the environment, rooms were not clean before patient admission. Also, the number of bacteria collected were small. I totally agree, and it's not by any way a critique, but it's already telling us how much we need to focus on the environment. We understand how much hand hygiene is important, and if you poorly do hand hygiene, probably it's impossible then to make the difference. If you are working so deeply, you could certainly mark and show the difference. So your paper is very important in this regard. So room for other questions. Fascinating discussion.
Yeah, so I had one on the first paper actually. So I think it's super interesting trying to sort of tease apart the question of contamination versus transmission, and were there any transmission patterns either in terms of the fomites or the types of pathogens that surprised you when you were doing that review?
Well, the first paper, was limited only to MRSA and VRE because they didn't have enough studies on other things such as C. difficile and CRE. I don't know that there was anything startlingly there. I think these days we would think of MRSA as a more important pathogen than VRE. With the newer antibiotics, the days when we really didn't have good therapies except aminoglycosides in some cases for VRE, and now that we have a number of more antibiotics, so there's less concern about VRE transmission there. But I do always, one of my favorite papers, importance of hospital design, is a paper by Gary Noskins where he looked at in hospital rooms with fabric chairs, and of course patients wearing little flimsy johnnies and then sitting on the chairs demonstrated VRE transmission because you really can't, there's no way to disinfect a porous surface easily. So he demonstrated transmission from those fabric covered chairs, which is why hospitals should have impervious surfaces there for VRE. So that was an interesting paper there. But I think some of the things in that first paper were particularly important to me, things like how often the hands were contaminated after glove removal. And they also clearly showed the importance of the environment as well. It wasn't always just, a patient to hand to patient or patient to glove to patient. It was clearly the environment was playing a role as well as so. Again, I think these type of papers really dovetail well with the paper that Dr. Cannon presented, now beginning to disentangle actually how the transmission occurs when patient goes into a room with a previously colonized or infected patient.
Thank you. And in the second paper, where you were saying that from the study, you estimated the acquisition from the environment of NDROs to be between 10 and 30%. I thought that was especially elegant. Are you aware of any other prospective studies that came up with numbers concerning that? Because I'm not.
I'm not aware of other studies that came up with definitive numbers beyond just guesses.
So you're gonna we're gonna have a slide of that pretty soon. Thank you.
Yeah, when we look for it for MRSA 20 years ago, but of course it may vary from one region to another and so on. We got several % of patients colonized. Now, of course, it depends on the type of ward you are looking for, and if you are in a cancer ward where patients are coming in and out and for the past months and get colonized because of multiple antibiotic therapy and so on, it may be different than if you are in a primary care facility in the middle of nowhere. But it's clear that somewhere we are still always on the same parameters. The patient are coming in, they are colonized or they are not, and very, very quickly we can see that they can acquire from the environment or they can give to the environment. And I think that we are getting more and more papers that support our actions, whether it's hand hygiene. We all know that this is important. What I'm afraid of is that when people are promoting hand hygiene, they have the feeling that if they don't suppress every transmission, they will not accomplish the job correctly. But it's more complex than these. Yes, hand hygiene is important. Glove use and glove removal is absolutely key, and hand hygiene after glove removal. But still, the environment is definitively playing a role that is certainly extremely difficult to demonstrate, but that is real.
Yeah. Do we have
More
any other
questions?
May I, this is Syed Sattar. Thank you,
Hi,
David,
Syed.
for that excellent presentation. I just wanted to make one comment that we talked about the presence or absence of moisture during transfer from hands to environmental surfaces, vice versa. There are two other variables that one should add to that list. One is the level of pressure between the two surfaces during contact, and the other one is friction. We have actually quantified that and published data to address these two variables as well. And I have several questions. Of course, we don't have the time, but I do appreciate your presentation. Thank you,
We do,
David.
yeah, we do have the time. So
Okay,
we
if
do.
you
So
have the time, then I have one question. David, there is a lot of talk about formulations with persistent or long-term activity, microbicidal activity on environmental surfaces. This is an active area of research and development. I just wanted to know your views and your experience in that regard. Do you think that that technology has a place? And if so, what do you consider as the merits of it?
So I think the answer is yes, it has a place. So that's clearly the holy grail, both of surface disinfection, at least one of them, and hand hygiene, to have an agent you could put down that would have persistence, at least for 24 hours. In terms of the environment, we've studied two products. One was a silver product we studied decades ago and did show that, one, it didn't rub off, and two, if you challenged it 24 hours or even later with microorganisms, it was still quite active. It was never surfacing. It was never really commercialized, I think, because of the expense. More recently, we studied the PDI product, Sani 24, which is they're no longer making. It was a little more expensive, and I think hospitals are not willing to pay for it. Plus, it was a little sticky, which put them off. We've shown when we studied disinfection of keyboards that the quaternary ammonium compound did provide persistence, but it was easily rubbed off. Sani 24 we showed with persistent using an EPA method where you talked about the points of pressure and friction. The surface would be put down and then it would be rubbed multiple times with at a specific number of times and a specific pressure. You standardized all of that, and we showed that it didn't rub off and that you could challenge it up to 24 hours and still have a die-off. That product is not available. But I think a number of other companies work hard at work at other products, and I think we will likely see either self-disinfecting surfaces. I think people are looking at heavy metals like copper, but it's really an active area of research, and I think it's certainly one worth doing that will help reduce the importance of the environment and mean that you don't necessarily have to touch each part of the environment every day. So I think that's quite important, but I don't think that we can point to a single product yet and say there's good evidence that this will work. What was your other question?
Thank you, David.
Yeah, you had another question, Syed?
Have no more questions.
Well, one question I would have, because we have the world experts around the table. Obviously, in the first paper, they had only papers to study MRSA and VRA and even not C. diff. And in the second paper, you look for, of course, multi-resistant bacteria. But what about viruses and the environment? I mean, I'm convinced that, of course, it's extremely difficult to identify, but I'm convinced that the environment is absolutely key even in virus cross-transfer. So, Syed, you are on board. You are with us.
Okay.
Any comment?
I'm glad
You
that
gave a fantastic journal club and
thank you.
session to us. But so for all of those who are not here, and
Yeah.
what's your takeoff of the literature and of the field? You are one of the world experts.
Thank you. Yes, I do agree that there is a lack of data, good quality data with regards to viruses. The reason is obvious because recovery of viruses from the environment or even from hands is a very difficult challenge. Now, we have been focusing on indoor air as a potential for spreading viruses, particularly respiratory viruses. And we have recently come up with a technique where one can recover or aerosolize and recover viruses of human and animal health. For example, a surrogate for human coronavirus, a surrogate for human norovirus, and so on, quantitatively from the air. And that is still a matter which is under development. And we are hoping that once that technique is perfected, we may be able to use it to try and detect human or animal pathogenic viruses in indoor air in actual field settings. This is our objective at the moment. But the very reason for there is lack of data on virology is the need for the use of cell cultures. Animals we don't encourage the use of, but cell cultures to recover. And this is where there has to be a breakthrough in us being able to detect viable viruses in environmental samples. And that stage we still have not reached, because not only viruses are difficult to work with, but field strains of viruses are even more difficult to recover from the environment.
Yeah.
We have done studies looking at how well gloves and personal protective equipment work on things like double gloving and other issues using 5.6, which is a non-envelope virus, and MS2, an envelope virus, and MS2, a non-envelope virus, and but doesn't get at the question of viral transmission, but it does show that standard personal protective equipment often leads to contamination of underlying hands and skin. Particularly important when you think about highly significant organisms such as Lassa and Ebola and Marburg and others.
Mhm. Thank you. I guess John has a question. John?
Yeah, more of a comment. I'm thinking that one area that may benefit from additional research regarding the transmission of airborne pathogens has to do with trying to use more modern technology to establish how soon a person can enter a room that has been vacated by a patient with a pathogen that's potentially airborne. I mean, CDC has had a method that they recommend for probably decades, which to me is rather outdated at this point. During the SARS pandemic, there was some concern about how soon housekeepers should go into a patient's room after the patient left the room. And now, I think Dr. Weber mentioned a day or two ago that a few cases of measles may have been acquired an hour or two after a patient left a room and someone else came in and acquired it. So I think the question is how do you determine when it's safe for a person to go into a room that's been vacated by a patient like that? And during the COVID pandemic, there was some interest in using CO2 monitoring, and some fairly complex studies published by a group at MIT has looked at this issue, and I think shed some light and maybe even suggested some practical cutoff points about what your CO2 level might be in the room when it's safe to go back in the room. And so this is an area where I think it would be fruitful to at least have a look at CO2 monitoring as a way of establishing when the risk is low after a patient has vacated a room like that when they had an airborne pathogen.
So it's we looked at many years ago, Bill Rotella and I, at how well HEPA portable machines work using an aerosol, special aerosol room, and looking at small droplets, not actual infectious particles. And it's really easy to measure how quickly, based on air exchanges and filtration, you can clear a room. What's not really well known, unlike gastrointestinal pathogens, where we have a pretty good idea for many of them, what the inoculating dose is, and you can do human challenge studies, and we've done it for things like norovirus, what the actual inoculum dose is to acquire influenza. How many particles do you have to inhale over what period of time, and doesn't matter whether mouth breathing or nose breathing. So you can figure out how the particle, and you can measure the particles in the air, that is the density. Again, that's fairly straightforward, and you can measure clearance, but I think there's much more limited data on knowing what the inoculating doses and how it might vary by things like age and immune compromise and so on to really help entirely with that. But if we can get data like CO2 that actually correlates with infectivity, that would be useful, but I just have to probably do it for each separate virus. I don't know that, just like GI pathogens, you could say if you could determine what the risk is for COVID, it would automatically tell you what the risk is for measles and influenza and varicella.
I think my idea would be to have a group like yours or others who can do those more sophisticated air changes and virology studies, because most hospitals, frankly, don't have that capability. Most hospitals don't even have special groups come in to measure their air exchange rates. The air exchange rates are often determined kind of when they finish building the place, and then they probably seldom, if ever, get measured in every room afterwards. And so to have a more practical method that could be used more widely would be helpful if it's based on your comments, if it could be related to infectivity likelihood, then something more practical, I think, would be useful.
Well, I'm currently, sorry, before we move to the next question, I'm currently looking at this CO2 data and these hypotheses of aerosol transmission in COVID-19, which is still totally unclear to me. I think there have been many papers, but most of those papers are very, very weak. Difficult to say, but it's true that we need some definitive advice. For measles, it's totally different because we published actually a paper where a physician came back in a room that was empty, that was occupied by a patient that actually had measles but was unrecognized and left the hospital to go to another structure, and then the physician who just passed across the room got measles. Mistake was that he was not vaccinated, but that's another story. So yes, well, when you have real aerosol transmission, but I know it for measles, I know it for tuberculosis, I know it for varicella, but I don't see any serious literature on most other viruses. And by revisiting these now, I can tell you that I'm totally disappointed by most of the papers that have been published. And that, of course, were highlighted during COVID because it was COVID and discussion and so on and so on. But it needs another discussion. But we are obviously moving for another mode of transmission. There is another question. Sorry for making you waiting. Oh, Jan, go ahead.
Hello, Ujana Sadian, Austria. Thank you very much for the excellent presentation. And also thank you very much for this very stimulating discussion, which I enjoy a lot. However, I have to say not without a bit of fear of the future, because what we heard today is that, well, we knew that the environment plays also a role in transmission. That was not new. But to quantify it, of course, and as Alexandra said, I already envision a slide which is now presented by 20 startup companies to me as medical director per week, telling me that there is a problem, of which I know, yes, we have a problem, but the big question is, what can we do against it? So during the past 20 or 30 decades, we said the most important is hand hygiene, including the proper use of gloves. But the reality and the truth is, to be honest, we all operate hospitals. And the fact is that if we respond correctly, we should do something with our surfaces. And I hear already, as I said, multiple startup companies telling me that their technology is superior than other technologies. And at the same time, we don't have an international consensus on should we tackle the problem, first of all. Secondly, what do we expect from measures? What are the qualities we expect from such measures? Clearly, to reduce transmission through the environment. But how? Spraying chemicals into the room, fitting every horizontal surface with an antimicrobial compound. Which technology should we use? So there is a huge lack of understanding what we really should do. And just to end my comment here, currently in Austria, in Wiener Neustadt, we are planning a new hospital facility, an 800-bed facility, which will serve for the next 2, 3, 4 decades. Now, the building costs are ridiculous in comparison to the running costs. And personally, and particularly the staffing costs of the hospital. So these antimicrobial technologies, for instance, are a one-off investment. It's really ridiculous from a financial point to say that this is a huge investment. My problem as a medical director, though, is I don't want to have 20 experts then telling me that we selected the wrong technology. So we should work now on solutions here, I think.
So I think you raised a very good question. There's obviously excellent data that improve cleaning of hospitals, reduces infections. There's substantial data looking at ultraviolet light for terminal disinfection and hydrogen peroxide vapor, particularly the hydrogen peroxide vapor. All the studies that have looked at healthcare-associated infections have shown reductions. So, but the key question you're asking is, which of the different modalities is the best? That we don't know. We don't have enough data. We don't have cost-effective analysis. The whole issue, and Dr. Boyce is an expert up there of that as well, on self-disinfecting surfaces and all the other competing technologies such as low-dose hydrogen peroxide vapor, near blue light, all these other ways so we don't have to actually physically clean the room and spray chemicals every day. We don't yet know which of those work, and we don't know which of those are going to be cost effective. So this is where things are still evolving. I will say, if you happen to be going to ECMID this year, and just at the end of the month in Barcelona, there is a session at ECMID on how to design the hospital to a way of reducing infections. And I will send, I'm giving one of the talks to that session. I'll send DDA my slides, and he's welcome to pass them around.
Jean-Yves has another question.
Yeah, I'm back. Is more common. So, I mean, yes, antimicrobial surfaces, there's lots of them. There's been lots of discussions. And you know, of course, David will know which one is some of them work, some of them do work less, but after that, it's cost effectiveness. You know, is it worth it? I've got more a comment on, as you know, my interest is on biofilms, and especially biofilm on dry surfaces. And from your second paper, where we still got quite a large number of microorganisms on surfaces, against the questions, especially that very nice table you showed, where you know that the microorganisms are transferred from the environment to the patient, is do you think that those dry surface biofilms can be responsible for that? And that was my previous questions about humidity, because I know with DSB, when the surface is dry, they're very not transferable. But when the surface is, we find that when the surface is disturbed, they're coming to be highly transferable. And nobody, I mean, looking in situ at DSB at the moment. But what have you got any comments on that, David?
So you raise yet another question about really that needs lots of research for the surface. We know to some extent, quite a bit, the importance of biofilms on implantable medical devices like heart valves, and how hard they are to eliminate if the patient gets infected with antibiotics. After that, we have knowledge and the impact of biofilms in lumen instruments like endoscopes, how frequently they're there, and the impact has on disinfection, which, of course, the presence of biofilm makes it much more difficult to disinfect objects. We know the importance of biofilms in P-traps and sinks, which again make it why there is really no definitive way of disinfecting that. And we're just beginning to learn more about biofilms on dry surfaces. Are they there? Yes. Are they important? Yes. They're best to prevent them from arising in the first place. Importantly, it may be that the data suggests that some chemical disinfectants are better at removing or inactivating the organisms in dry biofilms than others. But do we have any studies yet showing that if you use chemical A instead of chemical B, it actually reduces healthcare-associated infections more? The answer is no. So this is really an active area. And yes, I do agree with you that once those dry biofilms become a little moist, that enhances the biofilm and makes the disinfection easier. And in general, as a general rule, I would say with biofilms, you need physical removal, not just chemical inactivation. To actually, you do best if you physically remove the biofilm as part of your disinfection process.
Yeah, thanks, David. I was just going to say that. I mean, what we found and we published that in Asia last year, what we found for those dry surface biofilms, you need a combination of chemical and mechanical removal to be effective. Not just chemical removal doesn't work.
Thank you. There's one more question, I guess, or am I wrong? Yeah, go ahead. Andy.
Concerning the biofilm, I was
Andy Widmer from Basel.
asking the question if the probiotics, there are quite a lot of now companies providing some issues, in particular also from the group of Petra Gastmeier, showing that probiotics can have an impact on the biofilm formation on surfaces. What is your opinion on that issue?
I think that's certainly, and I agree, the data is suggestive for probiotics on biofilms or other, I don't know that I would call them necessarily a probiotic, but certainly the interaction of many microbes in helping reduce the importance of biofilms. Can we commercialize it? What the impact will actually be on transmission and or infections still remains to be determined, but I do agree the data, all primary, is very suggestive that will be an important adjunct, probably more important than trying to develop new chemicals there. So yes, another exciting area of research.
And I would say you are almost introducing one of our new next coming meeting or
May I just make one quick comment, Didier?
Yes, of course.
With
yeah.
regards to the use of so-called probiotics to prevent pathogens in the environment, I actually coined a new term, which is extrabiotics, to differentiate them from probiotics, which are ingested, but extrabiotics are probiotics for use outside the body and the environment. We are aware of one product which is commercialized in the United States, which is composed of a mixture of 3 types of spore-forming bacteria, which they suggest as a preventive measure against pathogens in the environment. I'm not entirely convinced of the utility of such an approach and also the long-term safety, because if you have a lot of spore-forming bacteria which you're disseminating in the environment, and they are, of course, stable by their very nature, what problems it might create, particularly in healthcare environment. That's an open question.
Which is clearly an open question for one of another of our journal club and meeting time, I guess. I don't see any more question, and I'm afraid we are coming to the end of the 90 minutes than we used to keep for this fascinating discussion time. I must say that I'm always very, very encouraged to see so many people attending and where we don't advertise for this closed meeting. Thank you very, very much. David, thank you very much for your work, for revisiting all of that. It was fascinating. Thank you all for participating. I'm turning to Alexandra to ask her if she wants to conclude and give us some housekeeping information.
Yeah, so thank you to everyone, as Professor Pite said, for joining. We look forward to seeing many of you in Amsterdam at Interclean And we will keep you posted, of course, for all of the upcoming journal clubs and think tanks and scientific sessions.
Thank you all.
Thank you
Thank you
very
very
much.
much. Bye-bye.
Thank you.
Thanks for attending.
Bye-bye.
Bye.
Thanks, David.
Bye-bye.